Third topic in the antenatal care module is the monochorionic twin pregnancy. Monochorionic twin pregnancies are common with assisted blood technology, especially when using day 5 blastocyst transfer, as it seems to have a significantly higher rate of monozygotic twin if we compare to cleavage stage day 3 embryo transfer, and it's more common as well with old maternal age. These are factors which increase the risk of having monochorionic twin gestation. Generally speaking, we have three different types of twins, either monochorionic monoamniotic twins, in which the two fetus share the same amniotic sac and the same placenta, monochorionic diamniotic, in which they share the same placenta but each one has its own sac, and diamniotic dichorionic, in which they have two amniotic sacs and two placenta. For monochorionic gestation, where they share the same placenta, there usually is an arteriovenous anastomosis within the placental vasculature, which permit blood supply from one twin to another and vice versa. Generally, it's an arteriovenous anastomosis, and accordingly there is no complication to either of twin. However, when it is monodirectional anastomosis, it will result in a complication of one of both twins, as one will be the donor and the other will be the recipient. Most common complications is preterm birth, fetal growth restriction, increased risk of preeclampsia, increased risk of postpartum hemorrhage, and increased risk of postnatal complication. These are general complications for twin pregnancy, plus increased risk of maternal anemia. Specific risk for monochorionic twin gestation. The first one is twin-twin transfusion syndrome, in which there is monodirectional anastomosis within the placenta, so the blood flow from one twin, which is the donor twin, to the other twin, which is the recipient twin. It complicates 15% of twin gestation. It can be classified into 5 stages depending on the severity of the condition. So in the first stage, there's a difference in the amniotic fluid, in which there is polyhydramnios in the recipient twin, while oligohydramnios in the donor twin, but there is no difference in the Doppler flow parameters. Stage 2, the bladder of the donor twin is not visible and severe oligohydramnios. Still, Doppler studies are not critically abnormal. In stage 3, Doppler studies are critically abnormal in either the donor or the recipient. Typically, abnormal umbilical artery Doppler in the donor and abnormal venous Doppler in the recipient, in which there is reversed flow during atrial contraction within ductus venosus and or peristyle umbilical vein velocity. In stage 4, there will be ascites, pericardial effusion, pleural effusion, scalp edema, or overt hydrops, usually within the recipient. And in stage 5, one or both babies have died. The second complication is twin anemia polycythemia sequence, which complicate about 2% of monochorionic diamniotic pregnancies and up to 13% in twin who have fetoscopic laser ablation for twin-twin transfusion syndrome. In twin anemia polycythemia sequence, there is a difference in hemoglobin concentration between both twins, in which donor twin is anemic and the recipient is polycythemic. However, there must be no difference in the amniotic fluid, because if there is polyhydramnios or oligohydramnios in either twin, it will be twin-twin transfusion. And this is the main difference between twin-twin transfusion and twin anemia polycythemia sequence. This would be reflected in the midcellular artery peak systolic velocity. So in the twin who had polycythemia, the midcellular artery peak systolic velocity will be less than 1, but the twin who have anemia, or the donor twin, the peak systolic velocity will be more than 1.5 multiple of median. Selective gross retardation or gross discordance, when the estimated fetal weight difference between both twins is more than 20%, even if the estimated fetal weight of both of them is more than 10 centile, still there is gross discordance, still it's high risk for complication. Gross discordance can be calculated using equation of estimated fetal weight of larger twin minus estimated fetal weight of smaller twin divided by estimated fetal weight of the larger twin multiplied by 100. It can be classified into 3 stages depending on severity. In stage 1, there is gross discordance, but there is positive diastolic velocity in both fetus. Stage 2, there is gross discordance with absent or reversed end diastolic velocity in one or both fetus. And in stage 3, there is gross discordance with cyclic umbilical artery diastolic waveform, which is the first stage of selective gross discordance. Growth discordance can happen due to either structural abnormality, chromosomal abnormality, or unequal placental sharing. Fourth complication, twin reverse arterial perfusion sequence, in which there is one twin is acardia and the other twin is normal, and in this case the blood flow from the normal twin to the acardiac twin, resulting in one twin is donor, which is a normal twin, while the other one will have increased perfusion. So we have Bombi twin and we have a recipient twin, and the transfusion occurs through large artery anastomosis. It complicates about 1% of monochrionic twin gestation. For monochrionic twin gestation, they must have the following appointments. They will have 11 to 14 week, which is a dating scan, and there must be labeling of chorionicity and screening for trisomy 21. The best time to detect chorionicity is between 11 and 13 and 6 days, and the photography should be kept in the notes, and if not clear enough, they must be photocopied and kept for the notes for a second opinion. Then you will have every 2 weeks from 16 week for the prediction of twin-twin transfusion syndrome. We do fetal growth and amniotic fluid using the deep vertical bucket as well as the umbilical artery Doppler every 2 weeks for early detection of twin-twin transfusion syndrome. In 20 weeks, we will have the tilde anomaly scan, and then we continue every 2 weeks till 36 week gestation. Here, these are the two main vascular complications which occur in monochrionic twin gestation. So as you see in twin-twin transfusions, there is large central artery to vein connection. That's why blood is flowing from donor twin to recipient twin, and accordingly one twin will suffer from oliguria and then absent bladder and then abnormal blood flow, while the other twin will suffer from polyuria or polyhydramnios, bladder will still visible, abnormal Doppler, and then pleural effusion, pericardial effusion, scalp edema, and then both twin will die. And the other is twin anemia polycythemia sequence, in which is tiny peripheral artery to vein connection. So one twin is a donor who is anemic, while the other twin is a recipient who is polycythemic, and this will be reflected in the midcellular artery peak systolic velocity index without affection on the amniotic fluid volume in either twin. Management of twin-twin transfusion syndrome. Usually these patients should be referred to fetal medicine center. If they are presenting early before 26 week gestation, should be treated by fluoroscopic laser ablation using the recommended Solomon technique rather than amnioreduction or septotomy, followed by weekly ultrasound assessment, especially of the umbilical artery Doppler and midcellular artery Doppler. And after 2 weeks post-treatment, if ultrasound Doppler is normal, the interval can be increased every 2 weeks. And delivery of monochrionic twin, which are previously complicated by twin-twin transfusion syndrome, but they are treated, is between 34 and 36 plus 6. Management of twin anemia polycythemia sequence. There is no clear evidence behind the optimal management. Again, patients should be referred to fetal medicine center with specialized care in twin anemia polycythemia sequence. Options can include expectant management with regular follow-up with midcellular artery peak systolic velocity, offer delivery, intrauterine blood transfusion, selective feticide, or fluoroscopic laser surgery. Management of selective growth restriction. Again, managed in fetal medicine center. In early onset selective growth retardation, usually is associated with poor fetal growth velocity and abnormal umbilical artery Doppler. Therefore, selective reduction can be considered. Surveillance of fetal growth at least every 2 weeks. Abnormal ductus venosus Doppler waveform in form of reverse flow during atrial contraction or computerized CTG show short-term variation should trigger consideration of delivery. In type 1, planned delivery should be considered by 34 to 36 weeks, as long as a satisfactory fetal growth velocity and normal Doppler. In type 2 and type 3, delivery should be planned around 32 weeks, unless fetal growth velocity is significantly abnormal or there is worsening of fetal Doppler, in which delivery should be indicated earlier. Please remember, in preterm delivery, should consider steroid and magnesium sulfate for neuroprotection. Another complication is single twin demise. After a single fetal death in a monochrionic pregnancy, clinicians should be aware of the risk of surviving twin of death or neurological abnormality in order of 15 and 26% respectively. Referred and assessed in fetal medicine center with an MTT approach in order to manage these cases. Fetal MRI of the brain can be performed 4 weeks after co-twin demise to detect neurological abnormality. If this information will be valuable in planning and management, this will depend on gestational age at which fetal demise occur. For example, if fetal demise occur at or after 32 weeks, in this case delivery usually for monochromic twin is planned around 36 weeks, so there is no rule of doing MRI before that. Fetal anemia can be assessed by measurement of fetal mid-cerebral artery peak systolic velocity using Doppler ultrasound. In summary, in case of single twin demise, you are afraid of two main issues. First is neurological abnormality, which can be detected by MRI of the brain, but this usually happens 4 weeks after the death of the twin, so not indicated except if the single twin death occurred very early in gestation. Second is fetal anemia. This can be predicted by regular male cerebral artery peak systolic velocity. Discordant abnormalities in monochromic pregnancy must be referred promptly for assessment and counseling in a fetal medicine center. Karyotyping is indicated. However, in karyotyping, if we are using amniocentesis, care should be taken to highlight which baby is which. So careful mapping of the fetus to right and left or up and down is particularly important in order to make sure that the sample is coming from the right fetus and the result will be reflective of which fetus is affected by the abnormality and subsequently the management. Selective reduction is an option. Thank you for listening to this presentation. It was based on NICE guideline of management of monoclinic twin gestation. Thanks.